Welcome to the deep dive. We're tackling a really significant issue today, something that touches the lives of our youngest and most vulnerable. Pressure injuries in neonates and children.
Yeah.
These aren't just, superficial marks. They're serious indicators of a patient's well-being and often, well, how well they're being cared for.
Mm-hmm.
Think of this as your shortcut to understanding the unique challenges around this often preventable complication.
That's right. And to get to the heart of this, we've really immersed ourselves in the chapter on pressure injuries in neonatal and pediatric populations. From wound care essentials, practice principles.
A great source.
Yeah, our mission is basically to extract the essential knowledge, give you a clear understanding of why these injuries happen and what makes preventing them so critical in this special population.
What's really encouraging, though, is the growing recognition of this issue. Organizations like Children's Hospital Solutions for Patient Safety, SPS they're called, and the Children's Hospital Association have joined forces. And they've made some impressive strides. By 2018, they achieved a significant 26.3% reduction in hospital-acquired pressure injuries across their network. That's huge.
That's really good progress.
And we should also acknowledge the NDNQI, the National Database of Nursing Quality Indicators, for their vital role in setting benchmarks and driving improvements.
Absolutely. That collaborative effort is key. And as our source material highlights, we'll be focusing on understanding how we assess a child's risk, identifying the specific factors that make their skin so vulnerable, and exploring the nuances of their skin and wound care.
Okay.
So let's dive in and unpack what makes their skin so different, shall we?
Absolutely. It's not just a case of smaller skin, is it? A baby's skin is fundamentally different from an adult's.
Precisely. A newborn's skin development is intricately linked to their gestational age. A premature infant, born around, say, 24 weeks, has a remarkably immature skin structure. Their stratum corneum, that crucial outer protective layer, it's incredibly thin, just a few cell layers compared to, the many layers in adult skin.
Wow, just a few.
Yeah. And the reed ridges, those tiny projections that help the epidermis and dermis connect, they're sparse and not well established.
Okay.
Which means even gentle friction can cause significant damage. Pretty crucial insight for handling these fragile patients.
So the skin layers aren't fully anchored together yet. That sounds incredibly delicate.
Exactly. This immaturity contributes to that often red, wrinkled, and almost translucent appearance we see in very premature babies. They also have minimal subcutaneous tissue, so the dermis lies very close to the muscle.
Right.
Now, here's where it gets really interesting. Around 26 to 29 weeks, subcutaneous fat begins to develop, which is why the skin starts to look less wrinkled. But the skin system isn't really considered fully mature until around 33 weeks.
33 weeks, okay.
That rapid development really underscores the vulnerability, doesn't it?
It's amazing how much happens in those few weeks. And even at full term, the source stresses that their skin remains incredibly fragile, right? And this delicate state continues throughout their first year.
That's right. This inherent immaturity, combined with factors common in a hospital environment, makes these young ones much more susceptible to skin injuries.
Okay.
Our source lists several key contributors.
Yeah.
Weakened connection between the epidermal and dermal layers, that thin stratum corneum we just discussed, a more alkaline pH on their skin surface.
Which isn't ideal for the barrier function.
Exactly. It can impair its barrier function. Then there's potential nutritional deficits, and of course the presence of necessary medical devices.
And we're not just talking about one type of skin issue, are we? The source mentions a few common injuries.
Yes. We often see epidermal stripping, essentially a superficial skin abrasion like a tape injury.
Okay.
Then there are extravasation injuries, which is damage caused by IV fluids leaking into the surrounding tissue.
Nasty stuff.
Yeah. Incontinence-associated dermatitis, or IAD, skin breakdown due to prolonged exposure to urine or stool, that's another concern. And of course, pressure injuries themselves. The source even touches on the ongoing discussion about classifying epithelial stripping from adhesive products as a pressure injury, which kind of highlights the complexities in data collection.
Ah, interesting point.
But the fundamental point, as our source emphasizes, is this. Pressure injuries in pediatric patients are intrinsically linked to their skin's immaturity and their smaller body size.
Okay, so their skin is more vulnerable. What about how frequently these pressure injuries actually occur? The numbers seem to vary quite a bit in the literature.
You're right. The reported prevalence and incidence in acute care pediatric populations show a significant range. The source points out that getting a precise benchmark is challenging.
Why is that?
Well, it's due to differences in study design and reporting things like the age groups included, whether patients were in critical care, the specific type of unit, even the definitions used for pressure injuries. You know,
Right, apples and oranges sometimes.
exactly. However, the increasing availability of national data for comparison is helping to refine our understanding, which is good.
So it's not always a straightforward comparison between different studies.
Precisely. But to give you some specific figures, overall pediatric pressure injury prevalence has been reported from as low as like 0.1% way up to 35%.
Huge range.
Yeah. Rasmus and Bergquist's 2012 data across 271 hospitals found an overall pediatric prevalence of 1.4%. When we focus specifically on neonates, reported rates range from 12% to over 31%.
Okay, higher in neonates.
And in the PICU, the Pediatric Intensive Care Unit, we see even higher numbers. Schindler and colleagues reported 10.2%. Noonan et al. Found 27%. And Schluer et al. A striking 44%.
44%, wow.
Yeah. Despite increasing awareness, pressure injuries in critically ill newborns can be alarmingly high, with some PICU studies reporting over 40%.
Those PICU numbers are definitely concerning. And the source even mentions that around 20% of injuries in both PICUs and NICUs are reported within the first 2 days of admission.
Yeah.
That highlights how quickly these can develop.
It's a critical point, underscoring how rapidly these injuries can arise in a vulnerable, often immobilized patient population. Schindler and colleagues also found an 18.8% incidence, specifically in PICU patients aged 0 to 3 months.
Okay.
What's fascinating here is the source's emphasis on the importance of individual healthcare facilities tracking their own data.
Right.
Because of the variability in reporting across different studies, understanding your own trends is paramount for quality improvement. You need your own baseline.
That makes perfect sense. You need to know your baseline to measure any progress. Now, the source also touches on specific populations. It sounds like we need more information in those areas.
We do. The source notes a lack of recent studies on pressure injury prevalence in specific high-risk groups, such as those with neurosensory impairment, spine deformities, or postural challenges. However, it logically suggests that the rates are likely higher in these populations due to their frequent use of orthotics, wheelchairs, and other medical devices.
Stands to reason.
And the fact that children grow adds another layer of complexity, right? You need regular checks to ensure devices still fit correctly.
Good point.
Hospitalizations involving surgery also increase risks in these groups due to factors like temperature fluctuations, unstable blood pressure and circulation hemodynamic changes, and increased fluid buildup, or edema.
Okay, so we have a better understanding of who is more susceptible and how common these injuries might be. Where on their bodies are they most likely to occur in children? Is it different from adults?
It is. The anatomical distribution of pressure injuries in pediatrics is quite distinct. The source clearly states that the occipital area, the back of the head, is the most common site for skin breakdown.
The occiput.
Yep, especially in children from birth to around age 3.
And why is that?
It's primarily because, proportionally, their head accounts for a much larger percentage of their total body weight and surface area. So when they're lying on their backs, the occiput becomes the main point of pressure.
That makes sense. A relatively large and heavy head on a smaller body. What about other common locations?
Well, Curley and colleagues identified the ear and nose, in addition to the occiput, as frequent sites. The nose in particular is at high risk for medical device-related pressure injuries, NDRPIs,
Right.
especially from non-invasive ventilation masks like CTAP. There's very little protective tissue between the skin and the underlying bone, so full-thickness injuries can develop very rapidly.
Scary.
Yeah. The mucous membranes inside the nostrils and on the lip edges are also vulnerable to device-related damage. Willick and colleagues' survey found the sacrum and buttocks, heels, thighs, ears, occipital scalp, ankles, and spine as common locations. And Kottner and colleagues' review highlighted the head, including ears and neck, followed by the heels and sacroiliacal areas. August and colleagues' study in neonates found over 35% of pressure injuries occurring on the head.
It sounds like the head is a major area of concern, especially in the younger years. But the source did mention that this might shift as children grow, right?
Exactly. In larger, less mobile children, similar to what we see in adults, the sacrum might become more vulnerable due to increased and prolonged pressure, particularly, with the head of the bed elevated.
Okay.
And let's not forget the ears. They have very little fat tissue, making them susceptible when oxygen, nasal cannula tubing, or NIV masks are used.
Right.
So the key takeaway here, the practice point, is that for children from birth to age 3, the occiput is the most common site for pressure injuries related to immobility.
Okay, we know the where. Now let's delve into the why. What are the specific risk factors that make neonates and children more prone to these
Well,
injuries?
as we touched on earlier, the traditional understanding was that pressure injuries were, pretty rare in pediatrics.
Right.
However, advancements in medical care have led to increased survival rates for critically and chronically ill infants and children, and that's really changed the landscape. Premature neonates, for instance, have a higher ratio of skin surface area to their body weight and less subcutaneous fat, which directly impacts their ability to tolerate pressure.
Mm-hmm.
Their anatomically immature skin is further stressed by the demands of intensive care, things like breathing difficulties, circulation problems, imbalances in fluids, and electrolytes.
It sounds like their bodies are working so hard just to function that their skin's resilience is really challenged.
Precisely. Additionally, their skin has a higher absorption rate compared to adults, which can paradoxically lead to dryness, flakiness, and a compromised skin barrier.
Interesting.
The source also draws a parallel to adults, noting that critically ill children can develop significant fluid buildup, edema from resuscitation efforts, and experience instability in their vital functions, which can contribute to unavoidable pressure injuries.
Unavoidable ones too.
Yeah. And prolonged immobility, especially with advanced therapies like ECMO and high-frequency oscillatory ventilation, HFOV, that's another major risk factor.
And it's not just tiny babies we're concerned about. Pediatric hospitals care for a wide range of ages, don't they?
Absolutely. Many pediatric facilities have variable age limits, so clinicians might be caring for everyone from extremely premature infants to obese adolescents, young adults, and sometimes even older individuals.
Wow.
This creates a significant challenge in ensuring expertise with a diverse range of support surfaces and skincare products. It's tough.
I can imagine.
The 2019 EPUAP, NPIAP, PPPIA guideline even includes 2 specific risk factor recommendations tailored for neonates and children, highlighting the unique considerations for this population.
We've discussed immobility as a risk factor, but it sounds like medical equipment itself plays a really significant role in pediatric pressure injuries, maybe even more so.
It truly does. The source emphasizes that medical devices are a leading cause of pressure injuries in neonates and young children.
A leading cause. Okay.
Yeah, as the number of life-sustaining lines, monitoring catheters, and other essential equipment increases, it often becomes more difficult to safely turn and reposition these little patients.
Right. Which consequently increases the risk of pressure-related injuries. In critical care settings, even something as seemingly simple as adjusting head position can be restricted due to the presence of central venous access catheters.
And I can imagine that with active children, or maybe developmentally delayed kids, there's a natural inclination to secure devices very firmly to stop them pulling things out.
Exactly. Clinicians often secure and stabilize devices tightly to the skin to prevent accidental dislodgement by active children or those with developmental delays who might not understand, the importance of leaving their equipment untouched.
Makes sense, but
But unfortunately, this increased pressure is a major contributing factor to skin breakdown. Data indicates that a significant percentage, up to 65% to 71% of all pressure injuries in acute care pediatrics, are device-related.
65 to 71%, that's huge.
It is. This is a notable increase from the previously reported 50%. Respiratory devices, IV lines, central lines, and tracheostomies are among the most frequent culprits. Non-invasive ventilation like CPAP and BiPAP seem particularly risky given their placement right on the face.
They are indeed. These therapies and their associated devices have long been recognized as a cause of nasal injury and even deformities. The masks need to be fitted and secured properly snug enough to maintain an adequate seal, but not so tight that they exert excessive pressure. It's a fine balance.
Tricky.
Yeah. The nasal wings, alae, the base of the nasal septum, caudal septum, the columella, the tissue between the nostrils, and the bridge of the nose are all vulnerable to injury from prongs, masks, and headgear.
Okay.
And it's not just the direct pressure. NIV masks can also trap moisture, altering the local skin environment and increasing the risk of breakdown.
The microclimate.
Exactly. Fisher and colleagues found a concerningly high incidence, over 42% of nasal trauma in NICU patients receiving nasal CPAP, with most of these injuries occurring within the first 6 days of therapy.
Wow, within 6 days. So what are the key steps that can be taken to prevent these device-related injuries? What are the best practices?
The source outlines several crucial best practices. It starts with ensuring the device is the correct size, performing thorough skin inspections and contact with the device at least daily, and being vigilant about how fluid buildup, that edema, around devices can affect their fit.
Right, because swelling changes things.
Definitely. Proactively cushioning and protecting high-risk areas before any signs of breakdown appear is paramount. For NIV, this means repositioning prongs or masks at least hourly, while also assessing the underlying skin and using protective hydrocolloid or foam dressings.
Hourly checks and repositioning.
Yep. The EPAP, NPIAP, PPPIA guideline even suggests alternating oxygen delivery methods, such as switching between a mask and nasal prongs if it's medically safe for the patient.
That makes sense, giving one area a rest while still providing the necessary respiratory support. What about preventing injuries from other types of devices, like pulse ox probes or tracks?
Good question. Murray and colleagues recommend changing the location of oxygen saturation probes every 2 to 3 hours, and even more frequently in critical care. Orthotic devices should be removed 2 to 3 times daily to allow for thorough skin checks, and dressings under tracheostomy and enteral feeding tube sites should be changed 1 to 2 times daily to maintain a clean and dry environment.
And document if you can't do it.
Critically important. If any of these actions are medically contraindicated for a particular patient, the reason must be clearly documented.
Right.
McCord and colleagues' study in PICU patients identified edema, a PICU, stay longer than 96 hours. Increased positive end expiratory pressure, PEEP, on the ventilator, weight loss, and not turning the patient or using a specialty bed as additional risk factors for pressure injury development.
We've touched on some special populations briefly, like kids with neurological issues. Does the source provide more specific details about pressure injury risks in these groups?
Yes, it specifically highlights paralysis and loss of sensation, such as in patients with spinal cord injury or myelomeningocele, as significant risk factors.
Makes sense.
Ekmark's report emphasizes the risk of skin damage due to sliding forces or shear injuries during wheelchair transfers, and the crucial need for comprehensive patient and family education on repositioning at least every 1 to 2 hours while in a wheelchair.
So important.
Specialized seat cushions require annual reassessment and also after any spine or lower extremity surgery. Regular checks of new orthotic braces, especially around 2 and 12 months after they are fitted and with any significant weight changes, are also vital.
Growth spurts, yeah.
Exactly. The source stresses the importance of ensuring correct fit and educating caregivers on daily skin inspections, proper cleaning, and a gradual approach to introducing new orthotics. Don't just slap it on for 12 hours straight away.
Right, gotta ease into it. And they can't rely on feeling pain or discomfort to alert them to a problem.
Exactly. Schottler and colleagues' review of children who sustained spinal cord injuries before the age of 5 found that a concerning 41% had a history of pressure injury.
41%.
Yeah, with over 70% occurring on the feet and ankles.
Feet and ankles, interesting.
And Samanigo's study on pediatric outpatients with myelodysplasia identified paralysis, areas lacking sensation, high levels of activity combined with periods of immobility as all contributing to their risk of pressure injuries.
So it's not just about being confined to bed. Other factors related to their specific medical conditions play a major role. Now, how do healthcare professionals actually assess a child's individual risk for developing these injuries? Are there specific tools they use?
Absolutely. The source emphasizes the importance of using objective criteria to determine a patient's individual risk, quantify that level of risk, and guide the implementation of appropriate preventive interventions.
Makes sense.
Patients identified as being at higher risk have a significantly greater likelihood of developing a hospital-acquired pressure injury, or HAPI. It's also crucial to differentiate between pressure injuries caused by immobility and those caused by medical devices, MDRPIs.
Right, because prevention might differ.
Exactly. The strategies for preventing and managing them can differ. While there are several risk assessment scales specifically designed for neonates and children, only a few have published data on their accuracy in predicting risk, their sensitivity, and specificity.
Okay, so which ones have the evidence behind them? What are some of the key scales that the source specifically mentions?
Well, Schumacher and colleagues developed a short trigger tool for use in the NICU. It's like a quick initial screen to identify infants who might be at risk, although it doesn't provide a quantified risk score. Useful first step, maybe.
Okay.
But for a more comprehensive assessment, the source focuses on the NSRAS, Neonatal Skin Risk Assessment Scale, the Braden-Q scale, the Glamorgan scale, and the newer Braden-QD scale.
Got it.
The NSRAS was developed specifically for neonates back in 1997, modeled after the adult Braden scale. It evaluates 6 factors relevant to newborns and initially demonstrated good sensitivity and specificity, but, neonatology has advanced since then, suggesting it might need a revision.
Okay, makes sense. And the Braden Q is probably a scale that many healthcare professionals are familiar with, right?
It is. Developed in the early 1990s, it's widely used in pediatric settings and has been shown to be a valid and reliable tool. Quigley and Curley adapted the adult Braden scale by adding a subscale to assess tissue perfusion and oxygenation, which is particularly relevant in pediatrics.
Ah, good addition.
Research has indicated that it's quite sensitive in identifying at-risk patients, although its specificity correctly identifying those who will not develop a pressure injury is lower.
Okay.
It's important to note that the original Braden Q was not specifically designed to predict injuries caused by medical devices.
Ah, a key limitation now.
A key limitation, yeah. Because of this, the authors now recommend using the Braden QD scale instead.
Okay. What are the key differences with the Braden QD? How does it improve things?
The Braden QD, which was published in 2017, is specifically designed to assess the risk of both immobility-related and medical device-related pressure injuries.
Both types. Good.
Yeah, across a broad pediatric population, including children with congenital heart disease, who are often excluded from earlier studies. It has been validated for use in preterm infants up to young adults, age 21, who are on bed rest and have medical devices.
Wider range.
Exactly. The Braden QD removed 2 of the original subscales from the Braden Q and added 2 new subscales that specifically address device-related risks. The scoring system was also adjusted.
Makes sense.
Validation studies have shown similar levels of sensitivity and specificity to the Braden Q, and there is increasing interest in and availability of educational materials for the Braden QD scale.
Okay.
In essence, the Braden QD is emerging as the preferred tool because it specifically addresses both immobility and device-related risks, making it more relevant in today's technologically intensive pediatric care.
So it sounds like the Braden QD is becoming the go-to assessment tool. What about the Glamorgan scale? You mentioned that one too.
The Glamorgan scale is another option that does include an assessment of medical device-related risk. It was developed based on a review of the literature and expert opinions, focusing on factors believed to contribute to pressure injuries in children.
Right.
It scores factors related to mobility and the presence of equipment, with a weighted score if any equipment is directly pressing on the skin. A score of 15 or higher indicates a high risk.
Okay.
Studies have shown it to have high sensitivity, meaning it's good at identifying patients who are at risk, but its specificity is moderate. However, one study conducted in a low-risk cardiac unit found that it did not effectively distinguish risk in that particular setting. So, context matters.
It sounds like no single assessment tool is universally perfect for every situation. The source also raises an important challenge. How do you assess risk during longer medical procedures, like in the OR or cath lab?
That's a really critical point.
Yeah.
Assessing pressure injury risk during lengthy procedures in the operating room, radiology suites, or cardiac catheterization labs requires close collaboration.
Teamwork.
Absolutely. Between nurses, surgeons, and anesthesiology professionals. Patient positioning can vary significantly depending on the specific procedure, and it's essential to carefully assess the skin that will be bearing weight during the surgery.
Before, during, and after.
Exactly. Thorough skin assessments in the immediate period before, during, and after the procedure are vital, and any areas of compromised skin need to be clearly communicated during patient handoffs.
Handoffs are key.
Crucial. Current risk assessment tools don't fully address the specific risks for patients who were admitted after surgery and subsequently develop a pressure injury. Galvin and Curley have even developed a specific tool, the Braden Q plus P pressure injury risk assessment tool, designed for the perioperative setting.
Okay.
So the key practice point here is to always use a pressure injury risk assessment scale that has been specifically designed and validated for use in pediatric patients. Don't just grab the adult one.
Got it. Okay, we've assessed the risk. What's the next critical step in preventing these injuries? The source discusses pressure redistribution products, mattresses, and surfaces.
Right. Historically, as the source points out, support surfaces designed for adults were often used for infants and children.
Just smaller versions.
Kind of, but their effectiveness for patients with lower body weights and smaller statures is questionable. And the variability in the types and number of linen layers adds another layer of uncertainty.
Oh, the linens, yeah.
Many manufacturers only provide upper weight limits for their products without specifying minimum weight recommendations.
That's a problem.
It is. Milbrez and colleagues found a lack of comparative data for patients weighing less than 70 pounds and identified missing information on crucial aspects like pressure distribution qualities, the impact on positioning support, how bed movement affects pressure, and the degree of flotation provided under load. They also noted that comfort and quiet operation are important factors for patients and their families.
Mm.
Nobody wants a noisy mattress, right?
It makes sense. A noisy or uncomfortable mattress could be very disruptive, especially for a sick child trying to rest and heal. And what about the very specific needs of premature infants? They're so tiny.
Yeah, premature neonates often have very low muscle tone and may lie in extended non-flexed positions, which can actually hinder their normal neuromotor development.
Oh, right.
Therefore, routine repositioning using external support aids like gel or fluid-filled positioners is crucial to encourage a more flexed posture. The source strongly emphasizes recognizing each child's unique developmental and psychosocial needs when selecting support surfaces and positioning aids.
Individualize the care.
Exactly. Fortunately, there is now a wider range of both powered and non-powered options, specifically designed for pediatric patients, including specialized mattresses and overlays for use in isolettes, cribs, and incubators.
So children are definitely not just smaller versions of adults when it comes to needing specialized support surfaces.
Exactly. Adult low-air loss beds, for example, are often not suitable because they don't adequately accommodate the lower weight and smaller size of infants and small children.
Why not? What happens?
Well, infants and small children can even sink too deeply into adult cushions, creating new pressure points, paradoxically.
Oh.
Conversely, adult specialty beds that have a turning function can actually cause a small child's occiput to pivot on the same pressure point during turning, potentially increasing shear and friction rather than effectively redistributing pressure.
Not helping then.
Not helping. The recommendation here is to only use low air loss beds or alternating pressure overlays that are specifically age and weight appropriate, have demonstrated clinical efficacy and safety in pediatric populations, and are used according to the manufacturer's guidelines.
It sounds like clinicians need to be very informed consumers when it comes to choosing these products. Research is needed.
Absolutely. With a wide array of manufacturers and products available, clinicians need to carefully research both rental and purchased items. There's definitely a need for more comparative research, specifically in non-adult populations.
Right.
The National Pressure Injury Advisory Panel's S3I, that's the Support Surface Standards Initiative, is working towards establishing uniform terminology, standardized testing methods, and reporting standards for support surfaces, which should help.
Good initiative. Any specific products or findings mentioned?
Yeah, McLean and colleagues' 2002 pilot study found that the highest interface pressures occurred on the occiput in children from infancy to age 6, and on the occiput, coscinerex, and heels in children aged 6 to 18.
Okay.
They noted that a specific foam overlay resulted in the lowest occipital pressures for children under 2, and that the same overlay, combined with a gel-filled donut head support, effectively lowered occipital pressure and provided generalized pressure redistribution for children over 2.
Specific examples are helpful.
Yeah. The source also highlights non-powered fluidized positioning aids, such as the Mölnlycke Z-Flow, which are used to redistribute force and offload bony prominences while maintaining proper body alignment. These are widely used in NICUs and other pediatric environments.
Okay.
Newer technologies like the Pediatric Pulse Mattress Replacement System, designed for patients weighing between 0.7 and 45 kilograms, offer 3 zones of support and the option of static or pulsating low air loss, as well as microclimate management.
More advanced options.
All right. Air fluidized products and fluid immersion simulation technology are also used in specialized situations, like surgical overlays to prevent pressure injuries during very long procedures.
Right.
A final but crucial practice point here. Clinicians need to be aware of manufacturer disclosures regarding flame retardant standards for these products, and also consider the height of the mattress in relation to the height of the bedside rails to prevent accidental falls. Safety first.
Absolutely. Beyond specialized support surfaces, what role does basic skincare play in preventing pressure injuries in this vulnerable population, just keeping the skin healthy?
Frequent and comprehensive skin inspection is absolutely paramount, and it must be performed under all removable medical devices unless there is a specific medical contraindication.
Underneath everything.
Yes. The very materials used to secure these devices can sometimes impede thorough assessment and even contribute to increased risk. It's particularly vital to assess the skin underneath devices in patients who are unable to communicate any discomfort.
Like babies or sedated kids.
Exactly. Those with developmental delays, neurosensory impairments, or those receiving chemical paralysis, as well as in patients who have edema, which can affect how their devices fit.
Good point about edema again.
Yeah. Given that a significant proportion of pressure injuries in pediatrics are device-related up to, 50% or more frequent skin assessments, regular rotation of blood pressure cuffs, and transcutaneous oxygen monitoring probes, TCPO2 probes, and the consistent use of sufficient padding under various devices are essential.
It sounds like keeping a close eye on the skin is everyone's responsibility on the team.
Precisely. All members of the healthcare team, nurses, medical assistants, physicians, therapists, play a critical role. Collaboration between nursing and respiratory therapy is essential to safely reposition endotracheal tubes and non-invasive ventilation devices to allow for thorough skin assessment.
Teamwork again.
Always. Manufacturers of NIV equipment now offer a variety of masks, headgear, and chin straps designed to minimize the risk of skin breakdown. Integrating strategies for ensuring the proper fit of orthotics, feeding tube flanges, wheelchairs, and cushions as children grow is also crucial.
Keep checking that fit.
Yeah.
Yeah.
Proactively applying interface layers, such as foam or gel dressings, between medical devices and the skin can provide a significant protective barrier. Using moisture-wicking fabrics around tubes, skin folds, and surgical sites can help manage excess moisture.
Little things make a difference.
They do. Regular checks of beds and cribs should be done to ensure there are no foreign objects underneath the patient, like locked bottle caps or something.
Oh, yeah, good point.
When assessing the skin, tapes securing tubes and dressings should be removed gently, and the removal of EEG pads should be coordinated to avoid unnecessary skin trauma.
Okay.
The source even directs us to a valuable downloadable poster outlining best practices for preventing medical device-related pressure injuries in pediatric populations.
Great resource.
So the core message is clear. Frequent device repositioning, consistent skin protection, and routine assessment of the skin beneath devices are absolutely critical for prevention.
We often hear about the strong connection between nutrition and wound healing in adults. Is nutrition an equally important factor in preventing pressure injuries in children?
It is a highly significant concern in pediatrics. Clinicians must carefully balance the patient's underlying medical condition with the ongoing nutritional demands of growth and development. It's complex.
Right.
Pediatric patients often face unique nutritional challenges due to metabolic disorders, congenital anomalies, difficulties with swallowing, inadequate oral intake, increased metabolic needs due to illness, and even, selective eating habits that are common in different age groups. Picky eaters.
Yeah, that too.
The National Pressure Injury Advisory Panel, NPIAP, has published comprehensive white papers addressing the role of nutrition in both the prevention and treatment of pressure injuries in both adult and pediatric populations. The 2019 EPUAP NPIAP PPPIA guideline includes a strong recommendation for conducting age-appropriate nutritional assessments for all neonates and children who are identified as being at risk for pressure injury development.
So it's much more than just making sure they're getting enough calories. How does it work?
Absolutely. Malnutrition can significantly impair the body's ability, the tissue's ability, to withstand pressure, friction, and shear forces, especially in situations where there are shifts in fluid balance within the body, like third spacing.
Ah, yeah.
Specific nutritional factors that can contribute to an increased risk of pressure injuries include inadequate nutritional intake, low birth weight, low overall body weight, or unintentional weight loss, and dehydration.
Key factor.
Yeah. Therefore, a thorough nutritional screening upon admission to the hospital is essential, and addressing any identified protein, caloric, and hydration deficits should be a fundamental component of any pressure injury prevention and treatment plan. Obtaining and documenting accurate weight, height, and body mass index, BMI, at admission is crucial for monitoring trends over time. Collaboration with registered dietitians is highly recommended to optimize nutritional intake and to work collaboratively with children and families to address any specific food preferences or aversions.
Partnering with families.
Always. The source also emphasizes the importance of providing 247 support for breastfeeding mothers and initiating breast pumping when direct breastfeeding is not possible. And finally, respecting any existing dietary restrictions, like vegetarian or gluten-free diets, is essential to maximize a child's overall nutritional intake. Don't fight them on it if you don't have to.
Right, work with them. Okay, we've covered prevention strategies in detail, but what happens when a pressure injury does develop? How does wound care differ in this young population? It must be tricky.
When selecting topical agents for wound care in neonates and children, extreme caution is necessary. You have to carefully consider their age, the maturity of their skin, the specific condition of the skin surrounding the wound, how well the product will adhere, the potential for causing skin sensitivity or allergic reaction.
Absorption too, right?
Huge point.
Yeah.
the extent to which the product might be absorbed into their system, and the critical need to avoid products that contain dyes, fragrances, and preservatives.
Lots to think about.
Yeah. Knowing the specific safety profile of each product and adhering to the manufacturer's recommendations for use in neonates and pediatric patients is absolutely essential. The Association of Women's Health, Obstetric, and Neonatal Nurses, AHON, has developed valuable neonatal skincare, evidence-based clinical practice guidelines, which are available online.
Good resource.
For cleansing wounds, normal saline, sterile water, and gentle washing with mild soap and water are commonly used. Keep it simple. The primary goal when selecting wound care products is to maintain an optimal healing environment, managing moisture levels, humidity, pH, temperature within the wound, while also minimizing pain and preventing any further damage to the surrounding healthy skin.
What types of dressings are typically used for pressure injuries in children then?
Well, a variety of dressings can be appropriate depending on the characteristics of the wound. Amorphous hydrogels, plain and silver impregnated hydrofiber dressings can be used for treatment.
Okay.
Thin hydrocolloid dressings, foam dressings, thin film dressings, and silicone-based dressings can be used for both the treatment and prevention of pressure injuries.
Versatile.
Yeah. If there is non-viable tissue, dead tissue present in the wound, surgical or autolytic debridement might be considered if the goal is wound closure, unless there are specific medical reasons why it would be contraindicated. While there have been some anecdotal reports of using topical enzymes for debridement, manufacturers typically only recommend these products for use in individuals over the age of 18 due to a lack of established safety and effectiveness data in pediatric patients. So be careful there.
Right. Stick to the guidelines.
Medical-grade honey has been used effectively in some cases. Silver-impregnated dressings are another option to consider. But there are potential concerns regarding toxicity, particularly in very young children.
Toxicity is a big concern.
It is. The crucial practice point here is to always meticulously check the manufacturer's guidelines to ensure the safety of any topical agent before using it on a neonate or child.
Absolutely. And what about more advanced wound care therapies like negative pressure wound therapy or NPWT? Is that used in kids?
Negative pressure wound therapy, yeah, NPWT, it can be a valuable tool for managing extensive full-thickness pressure injuries, particularly as a way to promote wound healing in preparation for surgical closure.
Like a bridge to surgery.
Exactly. Stoffen and colleagues conducted a study on infants with abdominal wounds who were treated with NPWT for a median of 34 days. Their findings suggested that NPWT can be an important tool in these complex cases, but it does have contraindications, such as the presence of untreated osteomyelitis, bone infection.
Okay.
It's also important to be aware that NPWT technology currently lacks formal approval from the U.S. Food and Drug Administration, FDA, for use in patients under the age of 18. Off-label use, potentially.
Ah, good to know. It sounds like a very careful and evidence-based approach is essential when it comes to wound care in this vulnerable population. Now, the source also discusses something called pressure injury prevention bundles. What are these? Sounds systematic.
Pair bundles are essentially a structured approach to improving patient outcomes. They typically consist of a small set, usually 3 to 5, of evidence-based best practices that, when implemented together consistently and reliably, have been shown to lead to significantly better results.
Power in combination.
Exactly. The concept of care bundles is often credited to the Institute for Healthcare Improvement, the IHI. A comprehensive pressure injury prevention program frequently includes several key components. A thorough skin assessment conducted within 8 hours of admission and repeated daily thereafter.
Okay.
The consistent use of a validated pressure injury risk assessment scale with the development of an individualized care plan based on the risk assessment findings, and the use of an audit tool to regularly monitor compliance with the established prevention strategies.
Measuring compliance is key. How did they do that?
Well, auditing for compliance can involve reviewing paper or electronic medical records, direct observation of care practices, and careful skin inspections. Multiple methods.
And these bundles have been shown to be effective in reducing pressure injuries. They actually work.
Absolutely. High levels of adherence to well-designed pressure injury prevention bundles have been shown to reduce the rates of these injuries by as much as 30% to 40%.
That's a significant reduction. What might be in a typical bundle?
Potential elements of a pressure injury prevention bundle can include consistent skin assessment, accurate risk assessment, the use of appropriate pressure redistributing support surfaces and positioning aids, regular repositioning of the patient.
The basics.
Right, the core stuff. maintaining the head of the bed at or below 30 degrees whenever medically possible, keeping the patient's heels off the support surface, effective management of moisture and incontinence, meticulous skin assessment and care around all medical devices, routine rotation or repositioning of devices when feasible, and even the prophylactic application of soft silicone or foam dressings to high-risk areas like the sacrum.
Proactive dressings. Okay. It sounds like a systematic and multifaceted approach is really the key to successful prevention. Finally, what role do patients and their families play in preventing pressure injuries? They must be involved.
Their role is absolutely vital. Comprehensive education on the risk factors for pressure injuries, effective prevention strategies, and appropriate management techniques is essential not only for all healthcare providers, but also for children themselves when they're old enough, and their families, particularly those who have a child at high risk.
Empowering them.
Exactly. Empowering families with knowledge and skills builds their confidence and can significantly reduce the risk of pressure injuries, both during hospitalization and after discharge at home.
What are the key things to teach them?
Two teaching points should include how to avoid dragging or sliding during transfers and repositioning, the importance of frequent repositioning, ideally hourly when sitting, and every 2 hours when lying down, the need to avoid massaging any areas of skin that are red, warm, or tender.
No rubbing red areas.
Right, big no-no. How to keep the skin clean and dry, and the proper application of any recommended barrier ointments or creams. Parents should also be instructed to immediately notify a member of the nursing staff if they observed any areas of persistent redness on their child's skin.
Be vigilant.
And for children with darker skin tones, it's important to teach parents to look for changes in skin color, such as a purplish or bluish hue, or any areas that feel unusually warm over bony prominences and underneath medical equipment. Subtle signs.
Good point about skin tones. And what about when their child is discharged from the hospital? What should they focus on then?
At the time of discharge, parents of infants and children who are at high risk for pressure injuries should receive thorough instruction on how to perform regular skin assessments during routine care activities like bathing, diaper changes, and the application of any necessary medical devices. Make it part of the routine.
Integrate it.
Yeah. Even very young children can be involved in the learning process. Toddlers and preschoolers can be taught to perform basic skin checks on dolls or teddy bears, and even on themselves in a playful way.
Make it fun.
For school-age children who have good upper extremity function, they can be taught techniques such as lift-offs to relieve pressure when sitting in a wheelchair, how to use a mirror to inspect their own skin, and how to check their wheelchair cushions for any issues.
Empowering the child.
Exactly. Using reminders such as alarm clocks or watches can be helpful, and positive reinforcement through rewards can also be effective. As children grow older and become more independent, parents transition into more of a supervisory or safety net role.
Okay.
For teenagers, education should be provided in a private and respectful manner, using concise and task-focused materials. The use of watches with alarms to prompt repositioning can be particularly useful for this age group.
Tailor it to the age.
Absolutely. The fundamental practice point is that any teaching plan needs to be specifically tailored to the child's age, developmental level, cognitive abilities, and individual characteristics.
So to bring our deep dive to a close, it's clear that hospitalized neonates and children face a significant risk of developing pressure injuries, and they present a unique set of challenges for healthcare providers.
That's absolutely right. The pediatric healthcare environment demands a high level of specialized knowledge and skill to care for patients across a remarkably diverse age spectrum. Adult-focused solutions, as we said, are often not appropriate.
Right.
Which underscores the critical need for skincare protocols, support surfaces, and prevention strategies that are specifically designed for this vulnerable population. Adherence to established clinical practice guidelines and ongoing, comprehensive educational programs are vital, addressing the unique characteristics of their immature skin, their potential for absorbing harmful substances, the differences in how they distribute weight, and their distinct physiological and psychological needs.
And the cornerstones of effective prevention really remain the consistent use of a validated risk assessment scale in conjunction with thorough and frequent skin assessments and sound clinical judgment. Can't replace that.
Precisely. Recognizing that medical devices significantly increase the risk of developing device-related pressure injuries is the crucial first step in implementing targeted prevention strategies. And looking towards the future, further rigorous research is absolutely essential.
What kind of research?
Well, we need to gain a deeper understanding of the specific risks associated with current medical technologies and advocate for innovative design changes that can minimize the potential for pressure-related injuries in our youngest patients.
Yeah.
We also desperately need more high-quality data to determine the most efficacious pressure reduction interventions that are specifically tailored for use in neonatal children.
Lots more to learn.
Yeah.
Now let's take a moment to apply the wealth of knowledge we've just explored with a practical patient scenario drawn from our source material. Makes it real.
Good idea.
Okay, we have a 16-year-old male who is 4 days post-admission following a traumatic cervical spinal cord injury. He has complete paralysis and loss of sensation in all 4 extremities.
Okay.
He has a tracheostomy in place. The surrounding neck area is noted to be moist, and the skin immediately around the tracheostomy device shows signs of redness. His oxygen saturation levels are good, his vital signs are stable, but his hands and feet feel cool to the touch with a slightly delayed capillary refill.
Perfusion issues.
Yeah. He has an indwelling Foley catheter and is currently receiving total parenteral nutrition, TPN. He has several medical devices in place: a cardiorespiratory monitor, a pulse oximeter probe, the tracheostomy tube and its securing ties, a peripherally inserted central catheter, PICC line, and bilateral multipodous boots. So, based on the Braden-QD scale we discussed, how would we go about assessing his individual risk for developing a pressure injury?
Okay, let's break it down using the Braden-QD.
Mm-hmm.
Based on the information we have, we can score him on the traditional Braden scale components first. Mobility would be a 2, completely immobile.
Right.
Sensory perception would also be a 2, sensation in his extremities.
Right.
Friction and shear would likely be a 2, requires maximal assistance to move.
Okay.
Nutrition, well, he's receiving TPN with adequate calories, but spinal cord injury patients often have complex nutritional needs, maybe lower albumin, so let's be cautious and score that as a 1.
Okay, high risk there.
Tissue perfusion, given his cool extremities and delayed capillary refill, maybe borderline hemodynamics post-injury, let's score that as 1 as well. This gives us a total score of 8 on the core Braden scale components. Pretty low, high risk.
Right. Now, the device part for the QD.
Right. Now, considering the device-related factors for the Braden-QD scale,
Mm-hmm.
he has a significant number of medical devices, let's count. Monitor, oximeter, track tubities, PICC, boots. That's at least 5 categories, maybe more, depending how you count the monitor leads, etc. Let's say 7 to be safe, based on the source example.
Okay, 7 devices.
And his ability to be repositioned safely and effectively is likely limited due to the PICC line, maybe spinal precautions, a track tube. So we might score his repositionability as a 2, difficult to reposition.
Right.
This would give him a total Braden-QD score of 17, based on the source's calculation method for combining these.
And what does a Braden-QD score of 17 indicate for this patient? What does that mean in practice?
A Braden-QD total score of 17 places this 16-year-old patient firmly in the at-risk category for developing pressure injuries.
Okay, so what interventions?
The recommended interventions should specifically target the areas where he received the lowest scores. He absolutely requires a pressure redistribution support surface to minimize pressure on bony prominences. Frequent meticulous skin assessments are crucial due to his complete lack of sensation.
Feeling.
Exactly. When repositioning him, it's essential to use appropriate turning and lifting devices to prevent any shearing or friction forces on his skin. His nutritional status needs to be closely monitored, with attention paid to ensuring adequate protein and calorie intake, collaborating with dietitians. We need to implement strategies to protect his skin from all of his medical devices as much as is safely possible, acknowledging the inherent limitations with things like the tracheostomy tube and PICC line. You can't always move those easily.
Right.
And finally, careful attention should be paid to padding and regularly repositioning all of his medical devices whenever it is safe and feasible to do so. Boots off periodically, pulse ox moved, etc.
That scenario really brings all of these important concepts to life. Great example. Now, before we conclude, let's do a quick show what you know to reinforce our learning with some multiple choice questions directly from our source material. Ready?
Ready.
First question. Maturity of the integumentary system is complete at approximately which week of gestation? Your choices are A, 40 weeks, B, 28 weeks, C, 33 weeks, or D, 36 weeks.
We talked about this. The correct answer is C, 33 weeks.
Correct. Second question. What is the most prevalent area for skin breakdown in neonates and children to occur? Is it A, sacrum, B, ear, C, occiput, or D, heels?
WCE, occiput, the back of the head.
Got it. And finally, which one of the following is a pressure injury risk assessment scale that can be used for a 5-year-old child? A, Braden scale, adult, B, Waterlow scale, C, Norton scale, or D, Braden-Q scale and Glamorgan scale.
Okay, thinking about the pediatric specific ones, the correct answer is D, Braden-Q scale and Glamorgan scale. The others are primarily adult scales.
Excellent. Well, that brings us to the end of our in-depth exploration into pressure injuries in neonates and children. It's abundantly clear that their unique physiology and the critical medical care they often require create a complex environment when it comes to protecting their skin. It's a real challenge.
Indeed. We've highlighted the inherent vulnerability of their developing skin, the concerning prevalence and diverse causes of pressure injuries stemming from both immobility and essential medical devices, and the fundamental importance of implementing comprehensive risk assessment and prevention strategies.
Right.
These include meticulous skin care, the use of appropriate pressure redistribution support services, diligent and frequent repositioning, and the careful management of all medical devices. And we absolutely cannot overstate the crucial role that ongoing education plays, both for healthcare professionals and for the families who entrust us with the care of their children.
Oh. So here's a final thought for you, our listener, to consider. Given the rapid and continuous advancements in medical technology specifically designed for neonates and children, how can we foster further innovation in device designs and monitoring techniques to minimize the inherent risk of pressure injuries while still ensuring we can provide the necessary and often life-saving medical care?
Yeah, that's the million-dollar question. What new areas of research do you believe are the most critically important to pursue in this ongoing effort? Designing safer devices, better predictive tools, more effective surfaces.
Lots to think about.
That's a really important question to ponder. We strongly encourage you to delve further into the valuable resources we've referenced throughout our discussion today, such as the AHON Clinical Practice Guidelines and the NPIAP website.
Check those out.
Yeah, take some time to consider how this information applies within your own professional or personal context. Continuous learning and the application of critical thinking are essential to our collective goal of improving outcomes and enhancing the quality of life for these most vulnerable patients.